Let's look at a rare and interesting entity. Our patient is a 29-year-old woman who presented with a laryngeal lesion. She reported that the lesion had been present for more than 10 years, with recent enlargement leading to voice changes and dysphagia, which prompted her to seek medical attention. In the left upper image, we see a 2 cm polypoid mass protruding from the mucosal surface. The surface is smooth and intact, without ulceration. Imaging studies showed a well-circumscribed polyp with no worrisome radiologic features. The lesion was completely excised, and the resected specimen is shown here. At scanning magnification, the lesion resembles a fibroepithelial polyp with abundant myxoid stroma. On low-power examination, the surface squamous epithelium is intact. The underlying stroma is myxoid and richly vascular, with small clusters of inflammatory cells. Nothing particularly alarming is noted at this magnification. However, on high power, we identify cells with abundant eosinophilic cytoplasm and distinct striations. The nuclei are large with prominent cherry red nucleoli, features characteristic of differentiating rhabdomyoblasts. In another field, we see strap cells with elongated eosinophilic cytoplasm, again supporting skeletal muscle differentiation. Toward the center of the lesion, we observe spindle cells with fine chromatin and elongated eosinophilic cytoplasm. Similar spindle cells are also present closer to the surface. There is no mitotic activity, significant atypia, or necrosis. Immunohistochemistry shows that these cells are diffusely positive for desmin. This picture shows myogenin stain. We can see that many cells are positive. Some myogenin-positive cells represent mast cells showing nonspecific cytoplasmic staining, but a substantial proportion of the spindle cells demonstrate true nuclear positivity. Thus, the tumor is diffusely desmin-positive and focally myogenin-positive. What's the diagnosis? Fetal-type rhabdomyoma, FTR, is a rare benign tumor showing skeletal muscle differentiation. It occurs predominantly in children and is extremely rare in adults. Two types of rhabdomyoma exist, adult and fetal. We are most familiar with the adult type, characterized by differentiating rhabdomyoblasts with abundant eosinophilic cytoplasm, distinct striations, and spider cell morphology. Fetal-type rhabdomyoma, in contrast, is much less common and shows a gradient of maturation. More mature rhabdomyoblasts with abundant eosinophilic cytoplasm are found peripherally, while more primitive spindle cells with fine chromatin and scant cytoplasm are present centrally. Fetal-type rhabdomyoma occurs predominantly in children and is extremely rare in adults. Only about 30 adult cases have been reported in the literature. Most FTRs arise in the head and neck region, typically presenting as sessile or pedunculated mucosal polyps. These tumors lack invasive growth, necrosis, nuclear atypia, or increased mitotic activity. Immunophenotypically, FTRs are desmin-positive, diffuse, and myogenin/MyoD1 positive, focal. Clinical behavior is benign, with rare recurrences typically associated with incomplete excision. The main differential diagnosis is fetal-type rhabdomyosarcoma. The distinction is usually straightforward. Rhabdomyosarcoma is a high-grade sarcoma with mitotic activity, atypia, necrosis, and infiltrative growth, features absent in this lesion. In addition, FTR is usually small in size, and shows gradient of maturation. Fetal-type rhabdomyoma remains a very rare tumor, especially in adults. A list of reported adult cases is shown here. Once recognized, the diagnosis is not difficult, and distinguishing it from rhabdomyosarcoma is generally uncomplicated.